Check to make sure you can for me.
How's that?
Oh yeah, perfect. There you go.
Okay, so just minimize that. How do you do this? It's sharing this is screen. Yeah. You have to present it. No, I don't know. Okay, click. Great. You
Oh,
want me
there
to
we go.
start?
Perfect. Yeah, sure. Go ahead. Let me just introduce you. So we have the VA Maryland Healthcare System program here with the attending, the director, and two residents. So we'll just let them go ahead and take over. Go ahead, guys.
All right. Good evening. My name is Myra Abawi. I'm the program director here at the at the Maryland VA Healthcare System. And to my left, I have
Ashley, I'm a second year resident. And I'm Madeira. I'm PGY 3.
Background is that our program has a long history. We've been around since 1981 here in Maryland. We are a co-affiliate with Sinai Hospital Baltimore. Um, uh, the assistant director is Dr. Noman Siddiqui. If you guys don't know him, he's pretty well known and kind of pioneered he's known for his research efforts and his on minimally invasive surgery. Really excited that he's part of our program. He's been here since his fellowship. Our program is a podiatric medicine surgery residency program with rear for reconstruction, ankle surgery. That is what your residency certificate says at the end. We actually, fun fact, we were the first residency program in the country to be considered a rear foot certified program. So we have a very strong background in rear for reconstruction surgery. It's never an issue. The residents are usually done in their first year, almost at the tail end of their first year with all the rear foot cases. So here, Baltimore, Maryland, it's world-class medical institutions. There's diverse clinical experiences based on the being a tertiary referral center with all the hospitals we're affiliated with here in Maryland. We also have great cultural experience, and we are finally in the food. If you're a foodie, Baltimore is known for not only their food scene, but also their micro cafes. Here at the VA itself, we have the VA Maryland Healthcare System. We have Dr. Trent's our chief. We have Dr. Bramble and Dr. Chow. Sinai Hospital, we have Dr. Siddiqui and Dr. Bibbo. We also have the University of Maryland School of Medicine, which plays a big part in our training. Dr. Wines is a rotation director. Dr. Chow also has appointment, and Dr. Berger as well. The residents also spend time down at the DCVA healthcare system. Dr. Thompson is the chief, and we have 4 attendings. We have Dr. Raja, Dr. Atkins, Dr. Lamb, and Dr. Judd, who all bring a unique background in their to the residents' experience. The residents also spend time in some private hospitals that are community-based. Here at Adventist Hospital in Silver Spring, White Oak, they spend time with Dr. Blankins as well as Dr. Suduji. Our program currently, we have 3 residents, and we're actually accepting next year 4 PGY 1s in the following year. But currently have 3 PGY 3s, and for the third and second year, and 4 PGY 1s. It's during COVID, I decided after COVID to downsize the program to improve the volume of cases, and the residents exceeded the numbers and expectation now that we're back from COVID, and we're back to the normal 4 number. So numbers are never an issue for our residents. Like I said, by their second year, most of them are pretty much done with most of their numbers and the cases they needed for CPME requirements. We have a very robust academic schedule. The academic schedule is divided on a weekly basis based on CPME rules. And it's usually first Wednesdays, we call it Woo Wednesdays, for community podiatrists from across the state of Maryland, not only from like Johns Hopkins, from University of Maryland, Sinai, as well as community hospitals get together, and we talk about complicated cases or complicated wounds. So it's a great opportunity for residents not only discuss complicated cases with community doctors, but also engage them and talk about what they would do from other, with other attendings on what they would do and how to treat various pathologies in private practice. We also provide virtual journal club, and then once a quarter we try to meet in person over dinner to talk about, the journal article of the month. Third Mondays is very unique. Over the last 5 years, we've had dedicated time for the residents all day on Mondays towards board reviews, hands-on wet labs, either sawbones or wet lab, and then going over any other training they need hands-on. And it's an all-day thing, all-day academics where it's protected and can focus on the residents' education. And then we have radiology rounds where attendings come and go over and discussing just cases in general. So I think we have a very strong academic schedule and always open to tailoring the training based on the residents' needs of that year. Resident salary, I think we're pretty competitive when it comes to salary in our area. When it comes to Baltimore and the residents, don't really complain about anything, right? I think that's really competitive. It's you live in Baltimore, but you get DC pay. I think that's pretty nice. Since we're affiliated with Sinai, Baltimore Limb Deformity course, they go every year in August, where the residents learn the foundations of deformity correction, which is the epicenter of, here in Baltimore, the deformity correction center of training is always done here annually, and most of our residents go to this every year during their residency training and learn not just learning how to do external fixation, but understand the foundation of deformity correction itself. Some former residents here. This is Dr. Lamb when she was a resident at the course. So this is our schedule. I call this Tetris of residency for us. But as you can see here, there's a lot of moving parts and pieces, but the residents are across the board from their first to third year have exposure to vast majority of all not only the minimum requirements CPME, but really to maximize their education opportunity. A lot of the off-service rotations are done here in the Baltimore VA. We have a very close working relationship with all the attendings, and they rotate out quite a bit on the outside rotations as well. In general, this is the general algorithm outline of all the rotations based on your first, second, and third year. Recently, we had to change some of the outline because of the CPME changes that happened in the previous year. But overall, I think that it's a very well-rounded program. I'm very proud that the residents actually do work with pediatric orthopedists. I did my fellowship. I did my residency here in Baltimore, and then I stayed on, did my fellowships in pediatric orthopedics and deformity correction. So here at the Sinai Hospital, and our residents have an opportunity to work side by side, not only with the attendings and fellows, but have opportunity to showcase if they're interested in the fellowship. They're able to, decide on their own. Do they want to, continue their education? And always opportunities to work with various fellows. And I think it's great cross training in the program when working with fellows. Overall, these are the numbers. This is one of the numbers from a former resident who graduated. He did over 1,000 podiatric surgical procedures in his training. He could have done more and logged more if he wanted to, but he definitely met the maximum. So never an issue when it comes to overall numbers. You can see here, he did the resident did over almost nearly 300 rear foot cases, but also pediatric cases, about 115, which is a lot, right? So, these are real true surgical cases as well as clinical, but we definitely do a lot more pediatrics than the average VA would have exposure to. Research opportunities. I think we highly encourage most residents to partake in some type of research, if it's an abstract, if it's a paper, or is it just participating and tagging along into an established research subject. We encourage that quite a bit, or a chapter review. So it all depends on the residents and how engaged they want to be. Limb salvage, we take limb salvage and treat it like our patients are like on steroids when it comes to the vast majority of complex patients we get through shock trauma down at University of Maryland and the VA in Baltimore. It's not the most straightforward patients, but we are very proud on the exposure the residents do get in the complexity and the simplicity of some of the cases they have. The pediatrics, there's you do get a hands-on training when it comes to clubfoot corrections, no matter or vertical talus corrections, metaductus, and then the surgical treatment algorithm from conservative to surgical management for flat feet, skew feet, spastic deformities, toe walking, and a lot more. This is actually showcasing all the patients that I have in my practice and the residents doing surgical procedures on these clubfoot babies as well as the castings that are involved. Deformity correction, we do this, we emphasize this surgical biomechanics in our training. I think it plays a critical role. It's underappreciated in the education you get in podiatry school, and we tend to focus on that in the training itself. So this is actually one of our former residents up top, Navi at Sinai Hospital during one of his recon cases. Between Siddiqui and I, we have 2 decades worth of exposure to minimally invasive surgery. It's a big part of our training of our residents. The residents do still get open bunion, open forefoot, hindfoot surgery exposure, but our practice, I would say maybe like more than 50% of your bunion and hammer toe cases and overall are minimally invasive approach. So you don't be nervous about, oh, they just do MIS. No, they do everything. That's why we brought in other attendings in the other community hospitals and the other hospital systems who still do traditional open. So it's a unique part of the training. I think that seeing it on a weekly basis on how to approach MIS, not only in the simplicity of simple bunions, but the complex revisions or complex forefoot deformities, I think it plays a new role since there is a trend in minimally invasive foot surgery in our practices now. We also do a lot of congenital lengthenings. This is actually one of my patients here who was born with a congenital brachymetatarsia, and approaching it not only with traditional approaches but new or open approaches. You'll get exposure not only to monorail external fixation but acute correction with internal fixation is what we offer to the residents. Sports medicine and trauma, we also do as well. And you get this based on, what they say things come in threes. So residents will either get a handful of trauma when they're on call or they get a handful of acute injuries, but they get exposure to everything. So some rotations, they tend to go podiatric rotations, and this is our program. So I'm going to leave it up to Ashley and Adira to talk about their exposure here as the program.
Yeah, so I think that one of the reasons that this program was when I came here and visited as a student, I think that I saw things that I didn't see at any other place. And I think that residency is all about taking advantage of the opportunities that you have and the resources that you have, no matter where you go. But I think that this program stood out to me because there's such a unique set of endings and a unique set of pathologies that you get to see that, like I said, I didn't see anywhere else. And so I think that this really sets you up for not only like being able to approach any problem that you see, but just being comfortable seeing everything and approaching everything with good attendings to teach you.
Anybody have any questions? Or anybody have any questions you want to put in the chat?
Hi, Nyla.
Thank you to everyone
Hi,
for
everyone.
joining.
Yeah, I appreciate it. I have a question.
Yeah.
Do you guys, I guess it's kind of tough because you almost already answered it, but in terms of diversity, I mean, not just limb salvage, not just MIS, like, do you think you get everything? Sports medicine, peds, it sounds like peds already.
Yeah, so I think this program and specifically prepares us for basically everything that you're going to come out for in private practice or wherever you may want to. I think we're very well-rounded. We get a variety of, the trauma aspect. I think one thing and what really brought me to this program is Dr. Abawi specifically, because what anything that you may think you are lacking or might have an interest in, if you come to Dr. Barry and say, hey, like I have an interest in X, Y, or Z, and you come to her with a problem and a potential solution, she will fight tooth and nail for us to have that solution fixed. Like, we said, hey, we want a little bit more trauma exposure to our program. And she fought tooth and nail for us to get an extra trauma rotation to our program. So not only do we have another 2-month rotation at a trauma specific program, center within our program. But now now we have a 24-hour like every 3-day call within a level 1 level 2 trauma center.
Very busy level.
Yes, very busy level trauma 2 program, which Ashley will be experiencing very soon, coming up. So yeah, so any sort of problem you come with and you think, oh, you know what, I want a little bit more exposure to this or, whatsoever, you come to Dr. Abawi and say, hey, like, I want this, and you come with her with some solution, like, she's going to fight tooth and nail for residents. And that's one thing that really drew me to this program and why I chose this program, because like she stands behind her residents, what I consider like what she thinks as her children, really her children, like 110%. Right, Ashley? Yeah. Yeah.
I'm like a little tiger mom that I want the best for my children. So I'll fight tooth and
Yes.
But
Yes.
That's a good residency director to have.
Yes.
so for me, it's I'm a little biased. I'm a product of this program. I really think, and every program says this, we do a lot of recon, we do a lot of revision. I'm very proud of how much peds we do in our program. The one thing we were lacking was trauma. And so the difference between a level 1 and level 2 at this particular center is there's no in-house neurosurgery, right? So the residents will be side by side with the trauma surgeons, calling a code, doing treating a patient who's being, helicoptered in. So this rotation, it's the only level 2 trauma center outside of the downtown DC that they go to here in Maryland. So it's a very good change, but times are changed. Residents want to do more X depending on the resident group that we have, and they want to do more of one set of podiatry that we don't offer. We try to find a solution as long as we're within the means of CPME, which is the governing body of who we have. So my biggest thing is the program, for me, as long as the call is covered, people are cordial, everyone works together, I will do anything to make the experience for them better, because for me, I can care less about trauma because I wanted to do recon, but they want trauma. So I'm like, okay, what can I do to make things better? But that's the one unique part about our program, is that I'm very open-minded to constructive criticism. Is just the way I've always been as a resident, and I'm still like that as an attending, as a program director. I'm only as good as what my feedback is, and that's what I allow that opportunity for the residents. So there's no barricade in your opinion and your ideas. It's always like an opportunity to make things better for everyone.
Yeah, that's good to know. Very important. Yeah. Well, I don't think anybody else has any questions, so thank you guys for coming out, and we'll get this uploaded. Really appreciate it.
Thanks so much for
Yeah.
having
Yeah.
us.
Good luck with
Yeah.
everything, and have a Merry Christmas.
Thank
You
you.
too.
Yeah.
Bye.
Yeah.
Thanks.
Bye.
Thanks.